Bismillah ar-Rahman ar-Rahim. Good morning, everyone. And thank you, Mr. Chairman. Thank you for the organizing scientific committee for this invitation and for the excellent organization of this second Kuwaiti Gastroenterology Association conference. So my topic today will be about failed treatment for H. pylori. And in the next 20 minutes or so, I'll take you on a journey with H. pylori. These are my disclosures. So we'll be covering this agenda. So we'll go through the overview of H. pylori, treating the refractory infection, and how to improve the eradication rates. As you know that Helicobacter pylori is a difficult organism to be treated. It's capable of circumventing the harsh environment. Each part of the organism make it really capable of resisting the antibiotics. It has a flagellae. It's a gram-negative. It's actually penetrate the mucus layer and stayed actually away from the acid of the environment in the stomach. And it has also some genetic factors. So we know with this organism, you might get 20% chance of side effects or symptoms, including dyspepsia, acute gastritis, chronic gastritis, atrophic gastritis, and up to 50% of peptic ulcer disease are attributed to H. pylori infection. And there is a 3 to 6-fold increase in the adenocarcinoma of the stomach. And in 1994, the WHO classified H. pylori as carcinogenic type 1, in addition to multiple lymphoma and increased risk of ulcer bleeding in patients who are consuming NSAIDs. And there is a strong evidence now that it's associated with Arnold-Finzi anemia and ITP. Keep in mind that 30 to 40% of population are infected with H. pylori. So there are established benefits for treating and curing H. pylori. It will lead to resolution of the inflammation and eliminate the DNA damage that will probably stop the cascade of metaplasia and dysplasia, will reduce the cell turnover, restore gastric acid secretion, and cure the dyspepsia that's related to H. pylori, gastritis, ulcers, and early lymphoma, and also might prevent early gastric cancer. There is actually no deficiencies of antimicrobial and regimens. There are more than 30 regimens has been actually used to treat H. pylori. And looking at the comprehensive meta-analysis that was published recently, there is actually 50,000 patients actually included. And as you can see, resistance to the primary clarithromycin, levofloxacin, and metronidazole is increasing, and it will be more with secondary resistance. However, secondary and primary resistance to amoxicillin, rifabutin, and tetracycline are low. I think everyone has used clarithromycin-based therapy. Clarithromycin with amoxicillin and PPI, and some of you are still using it. It was first actually described in 1990 and recommended initially as first-line treatment, and over the past few years it has been abandoned because of the local resistance has been increased globally more than 15%. What's your aim? So if you are treating H. pylori, you have to keep in mind that your cure rate should be equal to or more than 90%. So what do we actually know from our data in Saudi Arabia that can be actually generalized maybe to Gulf region? We know that the first-line therapy, triple therapy, and sequential therapy based on our data are equal and suboptimal. Only the cure rate between 50 and 60%. The quadruple therapy, including the Pylori for 10 days, as first and second-line therapy are effective. And levofloxacin with doxycycline has been combined, and it was not really effective as rescue treatment. These are the data that was published. As you can see, the Pylori for intention to treat was only 78%. This is for both first and second-line treatment. ACP, which is amoxicillin, clarithromycin, and PPI, up to 50% only. And sequential therapy was almost the same, 50% for intention to treat, and for levo-based therapy as rescue treatment was only 36%. And this is actually one of the most important messages I would like to deliver. So the most effective strategy to manage refractory infection is to prevent refractory infection by improving the success rate of primary eradication therapy. So the selection of the appropriate eradication regimen should be adjusted according to the local antimicrobial susceptibility. These are the data that has been published about our team in 2015. We can know that metronidazole resistance up to 50%, clarithromycin was 23%, amoxicillin around 15%, which is really high compared to the European and North American data. Levofloxacin was 11%, and tetracycline was 2.3%. Looking at the Arab world, and we can expand the image to Europe, you can see the response to different antimicrobials. Looking at, for example, to the quadruple therapy in the middle for 10 days was 78%, but if we expand the quadruple therapy to the last line, which is 14 days, you can see it is up to 91%. So the only one regimen that has exceeded the 90% in this was the quadruple therapy. Pylori did really good job, like 89%, and levofloxacin bismuth quadruple therapy, quadruple including bismuth, amoxicillin, and levo, was 90%. So always when you treat H. pylori, you think that you are like going to an exam, you have to prepare for it, look at the data, look at this. So you'd like to pass the exam at the end. But unfortunately, if you fail the exam and your patient comes to you again with a positive, for example, urine test, you have to ask yourself, did I prescribe the correct regimen according to the local data? Was it correct duration given? And most of the data, they are pushing for at least 10 days, preferably 14 days. Acid suppression, was it adequate? Sometimes the patient go and collect antimicrobial, but don't take, for example, the proton pump inhibitors with it, or they take it in the wrong timing. And did the patient actually took the medicine? Sometimes they interrupt it, they travel, they take it for a few days, and they come again and resume the medications later on. I look at this image multiple times. It's very nicely written. Actually, it was published by American Gastroenterology Association in 2021. Looking at the factors causing the failure. It can be due to the host, it can be due to the system, and can be due to the bug. Keep in mind that antimicrobial resistance will explain only 50% of failure rate. So the bottom line, for successful eradication, you need to use the most effective treatment initially. So use it, and either you look at your cure rate in the area that you are working at, or looking at the culture and sensitivity per case, which is not going to be cost effective. So the culture and antimicrobial susceptibility can be done for many patients, but remember, it is really cumbersome, it's really costly, it needs really time to grow it, and it needs a special lab, and before you do it, you have to speak to your lab to make sure they are ready to do the culture and sensitivity. Nowadays, actually, we have the PCR technique that you can do it from the gastric tissue or the stool. It will detect the organism, and if it's positive, it will run all the resistance genes in the bug itself. It will detect, I cannot remember these numbers, but for example, the 2,3S RNA, this is, for example, clarithromycin. The second one is for levofloxacin. The third one is for amoxicillin, and so on. It has good sensitivity and specificity, as you can see, but again, it costs around $400 per patient per case. The host genetics also very important. We know that the polymorphism that will affect the metabolism of the proton pump inhibitor is important. We should really go and target patients with treating them in particular with the new generation proton pump inhibitors such as esomeprazole and rabeprazole because of the metabolism. Adherence to treatment, we cannot stress that more. Very important to stress on the patient to use it and to make sure that they are taking it in the right time, the correct dose, and sometimes you need to talk to the patient. There was actually a study that was published in the United States recently. Only 40% of physicians, they ask about the previous treatment. So many of the physicians, they don't look at the treatment before, they go and prescribe it, it failed before, and they go again and repeat the same mistake. 10% of patients will fail actually to even take 60% of medications. Keep in mind that taking 60 to 70% of the medications probably is enough, but usually we stress to the patient to take it up to 10 days or 14 days. So the eradication is more if the patient adheres to more treatment duration. Acid suppression, I think it is overlooked. We don't really give a good acid suppression. Sometimes we give it once a day or BID, but nowadays, no. Taking actually high-dose proton pump inhibitor or thinking about potassium competitive acid blockers like vonoprazan is more effective. According to the Maastricht 5 guidelines, the recommended BID dose for omeprazole, esomeprazole, and rabeprazole 20 milligram BID, for lansoprazole 30 milligram BID, and for pantoprazole is 40 milligram BID. For the very high dose, you can go, for example, with esomeprazole 40 milligram BID. There are many data showing that comparing the proton pump inhibitor, the new generations such as esomeprazole and rabeprazole, and recently dexlansoprazole are more effective than the old generations. Even if you look at the dose itself, for example, the esomeprazole, if you take 20 milligram BID and you advance it to 40 milligram BID, there is actually marginal benefit of adding high-dose proton pump inhibitors. And now for the PCABs, they are actually effective. They said biologically 300 times more potent than proton pump inhibitors. They actually work very fast and they have actually low side effect with good safety profile. So now, how to define refractory H. pylori infection? It is a persistent infection at least 4 weeks after stopping the antimicrobial, after treating the patient with the guidelines recommended antimicrobials. So there is no deficiencies about the guidelines. We have a lot of them. Unfortunately, some of them, they are local, based on low quality and heterogeneity of the clinical studies. Guided by the local antimicrobial resistance is very important. Avoid using the same regimen even for longer duration, with some exceptions. Longer treatment duration, minimum of 10 days, as we mentioned, and discuss the importance of the compliance with the patient and the use of high dose and more potent proton pump inhibitors or PCABs. This was published actually in 2021 by American Gastroenterology Association, looking at the failures of the first-line treatment. So if the patient has failed triple therapy, you can consider the quadruple therapy. And if the patient failed the quadruple therapy, now you probably get stuck. You ask yourself, is this patient true allergic to penicillin? If he is allergic to penicillin, some of the patients, they just label to have allergic to penicillin with just mild symptoms. If the patient has no penicillin allergy, you can really introduce it with levofloxacin or rifabutin. We have really a big question mark in our area. With our colleagues from ID, they would like to preserve rifabutin and levo for tuberculosis cases. However, we have limited options. We can use a concomitant treatment, which is you can combine all the metro, clarithromycin, and amoxicillin with high-dose PPI for a minimum of 14 days. If the patient is allergic to penicillin, so you have to avoid amoxicillin, you can retreat the patient with quadruple therapy, making sure the patient is taking it correctly and for a minimum of 14 days, and with high-dose proton pump inhibitors. If the patient failed this regimen for the second time, now it's the time to do the culture and sensitivity, and accordingly you target the treatment to the response. What guidelines recommend? According to the Maastricht 5 and Florence consensus, the bismuth quadruple therapy and levo triple and preferably quadruple therapy, adding bismuth to it, will be working. American College of Gastroenterology, they recommend actually the levo triple therapy or high dose dual therapy, depending on the sensitivity and allergy history to the patient. So quadruple therapy with the levofloxacin, adding the bismuth to it, amoxicillin, and PPI, it is better if you use it for 14 days rather than 10 days. Macrolides and fluoroquinolones should not be repeated in the subsequent treatment. Amoxicillin, tetra, and rifabutin can be used in the future. Amoxicillin usually go with higher dose, that the more the better, so up to 3 grams rather than like 2 grams. And even metro, if you can advance the dose to 1.5 to 2 grams, it will be more efficient. What happened if the patient failed the bismuth-based treatment? Now you have limited options. You can use the levo or rifabutin-based, concomitant, as I mentioned, and high-dose dual therapy. We don't have really enough data from the Gulf countries, but still we are going to probably work on the randomized control trial in the next few months. And as you can see, I put it for 14 days. Treatments after you fail second or third line, always advance it for 14 days. Always you have to think about, for example, probiotics. We'll talk about it. And after 2 failures, think about susceptibilities and culturing. And you always make sure that you discuss it with the patient, importance of the adherence to the treatment, and look at the local data again and again. Never just treat by yourself. Look at your colleagues, what they are doing, what's their experience with the treatment and response. For the probiotics, there is a lot of data in it. There is a lot of meta-analysis, systematic review, and most of the guidelines suggesting that it might help to improve the side effects, especially if the patient is taking it like in advance and during and sometimes after the treatment. So a single agent is better than combining actually probiotics. So the guidelines now, we have too many of them. We have the Chinese, we have the Maastricht, we have the Toronto, we have the American, we have the Saudi, and there are too many, and the Turkish. So if the patient failed the first line treatment, clarithromycin will go with the bismuth-based treatment. If the patient, for example, failed the bismuth-based treatment, you have to think about levofloxacin, rifabutin, or concomitant or high-dose dual therapy. Second-line treatment, according to our Saudi data that was published a few months ago, we do recommend actually bismuth-based and Pylori, which is bismuth-based for 10 days, and both of them actually equivalent. So what we need still more information about the success rate in the Gulf region. We can think about personalized therapy and incorporating all the data in the Gulf country and looking at the genetics, looking at the microbial factors, and we can look at the population-specific research, looking at the race, the ethnic groups, and the age, and joining actually the World Registry for H. pylori that started in Spain, now advanced to Europe and all over the world. We actually lucky that we joined this registry, and by joining this registry, we can actually combine all our own data, the efforts, the treatment, and the cure rate, and we can help each other. So Saudi Arabia started actually, now we have more than 50% registered over the past few months. So in conclusion, the H. pylori management seems to be now challenging, and local knowledge about the cure rate and success is very, very important before you prescribe it. For all therapies, increasing the duration will increase the cure rate for you. And bismuth-based quadruple therapy for 10 days, Pylori, or 14 days conventional is really effective as first and second line treatment. Consider the culture and sensitivity for your patients if failed 2 regimens. And for rescue treatment, we can consider concomitant levofloxacin-based therapy and rifabutin, with really question mark in our Gulf area for rifabutin and levofloxacin because of tuberculosis. Always consider 14 days duration. Adherence to the treatment and stressing on all of these factors with the patient is very important to ensure the adherence and compliance. Probiotic might help the patient and would reduce the side effect and adherence to treatment, but really the guidelines still against prescribing it with the proton, with the triple therapy. After multiple failures, you always look at the patient again. Do I need to treat this patient? For example, you are seeing an 80-year-old patient with a gastric ulcer or gastritis or duodenal ulcer. Is this patient really worth to receive PPI, receive antimicrobials with all the side effects, or just keep him just on a small dose PPI and eliminate the other factors like NSAIDs, and this will be enough for this patient? Thank you so much, and I'll be happy to answer questions.